Well, good evening, everyone. I am Carmela Roybal with the Health Equity Council, and I am here with my co-hosts, and I'll let them introduce themselves. I have Anna Horner.
Good afternoon, everybody. Welcome to our community dialogue. Thanks for joining us.
And I have my other co-host, Diana Lopez.
Hi, everyone. Good evening. Thanks for joining us. Diana Lopez here.
And we are the Health Equity Council. We are located here in Albuquerque, New Mexico, and we have a couple things going on this evening. So we'll be here for an hour. We have a very special guest, Mark Lamb, with us this evening. And at the same time, we will be handing out COVID tests, home tests, and we are encouraging everyone who joins us in person live. They're welcome to come by the studio and pick up tests for either their place of business, if your school, home. We're encouraging families, everyone, to keep these at home. We know they're very costly if you have to go out and purchase them in public. So you are welcome to drive by, and our address is 220 Suite A Adams South East, and we have our executive director, Enrique Cardial, who will greet you at the door. So you're more than welcome, guests, to come by and pick up COVID tests. Today we are introducing our program, Salud y Querencia. And so this is just a new kind of community dialogue talk that we wanted to bring community, we wanted to bring specialists to the community, and we wanted to go and take it a step further, you know, talking about what's happening in our community with COVID-19, what are the health trends, what's going to happen in the future around education gaps. And we have a lot of guests joining us monthly or weekly when we put these shows. So we just thank you everyone for joining us, and we hope that we all have something to, you know, share and learn from. I wanted to start by just describing Salud, which is health, and Querencia. So Querencia is just a term, and it's really special because it's the stronghold for New Mexican communities. You know, we drive, the word querer comes from the word love and where we place our stronghold. And so it's thinking about health and how we bind ourselves together to become strong as a community. So that's kind of like the impetus of our talks and us coming together and talking about that. This is part of, we actually want to maybe mention some of our supporters, the Health Council. I don't know if you want to talk about the community rebuild grant and other things that are supporting this effort. So
Yeah, we are one of the health councils across the state. So every county and tribe has a health council, and we are the Health Equity Council. We're representing here in Albuquerque and Bernalillo County. And there is a collaborative project of health councils called the Community Rebuild Project. So health councils across the state are coming together to talk about COVID-19 vaccinations, vaccine equity, health equity, capacity building and support, so that we can have a stronger community response to public health and health equity. And part of what we're doing here in Bernalillo County are having these conversations with folks. So creating space to talk about health equity, talk about public health, talk about COVID, talk about rebuilding, just to generate more conversation and get more people involved via those talks.
And I'd like to introduce Diana, who has been, you know, all the work that you've done around vaccine, and I don't know if you want to talk a little bit about your outreach, because it's been tremendous this entire.
Yeah, definitely. Thank you, Carmela. You know, through Department of Health as a health promotion specialist, we work alongside the Health Equity Council every single day. You know, working on vaccine equity, distribution of COVID test kits, planning. It's kind of a mixture of a lot of different things. So it really is nice to be hand in hand with community partners like the Health Equity Council and community members like you all watching tonight, and having Mark Lamb here as well to hear about their experiences. So it's really, I want to lift up that it's really a partnership and it's everyone working together. And I feel like since the beginning of COVID, that is something that has been strong in all of us and helping us move forward as we navigate the pandemic.
And so with that, I'd like to introduce our special guest, Mark Lamb. And if you'd like to just tell us a little bit about yourself and what you do in your role in this pandemic. So he's going to give us a very unique perspective that we haven't heard and we haven't had this conversation.
Sure. Well, thank you for hosting me and also for all of your work with the Health Equity Council. All of you do very important work. I'm a nurse practitioner. I'm certified as an emergency nurse practitioner and a family nurse practitioner. And I also have a master's in public health. Prior to becoming a nurse practitioner, I worked as a nurse. And I've spent the past about 4.5 years working in emergency department.
And what was your, so we really want to talk about your experience in the emergency department and, you know, handling the pandemic from its start to where we are now, and just kind of your lived experience as a professional, but then also the personal pieces to that.
Sure. It's hard to think back so far to when the pandemic first started. I would say that I don't think, as a healthcare provider, I don't think my experience is particularly unique. I think a lot of the stuff that I experienced was experienced across the country. And so a lot of what I'll be saying is like kind of generalities, but I can go into more depth if you'd like. At the beginning of the pandemic, I remember that we were coming off of a very busy flu season. So we're kind of like just getting a sigh of relief from getting out of flu season, which tends to be a very busy time of year in general anyway. But just that we were, you know, like already kind of tired. And as with the rest of the country, kind of watching the headlines about COVID in other countries and kind of wondering what was going to happen as far as both our country and the rest of the world. And I think also just getting access to accurate information was very important. So this is all well known, but you know, at the beginning of the pandemic, there wasn't a lot of testing going on. So true surveillance as far as the prevalence of COVID in the community wasn't well known. Also, just watching COVID hitting other health systems in other parts of the country and kind of wondering when it was going to happen in your own health system, I think was a source of anxiety for a lot of people. And there was this kind of interesting phenomenon of a calm before the storm. So people were avoiding the healthcare system, and in the emergency department, what that looks like is your typical emergency department complaints aren't showing up because those people aren't going to the hospital for those issues. And so we know that heart attacks and strokes and domestic violence and all these reasons that people come into the emergency department, we all know that that's still going on. So there wasn't, that kind of created, I think, an ominous feeling, just that all of these things are still happening, but people aren't coming in with it. And that in combination with the anxiety of waiting for what we were seeing in other parts of the country coming to our own healthcare facility was just very, very strange. It was very different from what it would typically look like in an emergency department. There was also just a lot of different information coming from a lot of different places. And at the beginning of the pandemic, there was just so many things that were unknown about the virus and how it was transmitted and the best ways for managing patients who have COVID. All of that seemed to change on a pretty frequent basis. For understandable reasons, more information was coming out, so things changed. But it just created a need to investigate a lot of the information that was coming out to make sure that you had a good understanding about why changes were being made. In part too, because as healthcare providers, we communicate to individual patients and families, and the general public were supposed to be trusted source of information. So to keep up with all of that, I think was also very challenging. Something as the pandemic was starting too was, I mentioned that we didn't have a lot of testing to get a sense of the prevalence of COVID in the community. And the way that showed up in an individual patient encounter was if a patient came in and they had symptoms for COVID, we didn't have enough tests to test everyone. And I think that was really frustrating for patients. And I think it was also frustrating for healthcare providers and for health systems. It was just the reality. We didn't have the resources to test everyone. But so I think patients walked away from that feeling very disappointed. And I think that just made things challenging. As we were learning more about how the virus was transmitted, and we were shifting resources to emergency care and the crisis at hand, we were like those resources have to come from somewhere. And so things like primary care and preventative services, I'm sure you saw this in the public health department too, all of those things that are really important for keeping patients in the community healthy and managing chronic diseases and preventing complications, all of those resources kind of got diverted. Well, not all of them, but a lot of them got diverted into the more acute crisis at hand. And, that can only last for so long before problems start to develop. And I think that's something that we saw as the pandemic continued. And I think we're still continuing to see the ramifications of that today. With subsequent surges, I think this became more apparent as, people started to come back into the emergency department with their typical emergency department issues. But then also all of those things that weren't able to be managed during that initial phase for understandable reasons, all of those things kind of led into further complications that, led people back into the emergency department. So then in the subsequent surges, you were dealing with your surge of COVID patients, but then also all of these things that kind of had to be set aside for the time being. It would be interesting to hear, I work in an emergency department, it'd be interesting to hear from people who work in services like surgery or primary care to get their perspective, because they face their own set of challenges as far as triaging issues to manage. And a lot of that stuff, there's a lot of nuance to that. So that's a different set of challenges. Another big issue that I don't know that it's gotten a lot of attention, but healthcare workers, like workers in a lot of other industries, we want to be tough. We want to be able to go to work and show up. And because when we don't show up, that creates a burden on the health system and trying to find coverage for our shift. It puts stress on our colleagues who we're close to and we don't want to let down. And so before COVID, if I had like a runny nose, sore throat, body aches, cough, but otherwise like feeling more or less capable of doing my job, I'd go to work. And all of that changed with COVID appropriately. But that created, for a health system, they then needed to be able to accommodate all of those people who were suddenly told that they couldn't come into work sick and they shouldn't go to work sick. So occupational health played a very important role in trying to manage all of those new sick calls that were coming in, and had developed a lot of policies and procedures for safely returning people back to work. And that's an ongoing issue, to be honest, for a lot of health systems, but I think it takes a lot of resources, and it's something that, doesn't get much attention. Another very big issue is that during flu season, we wear our PPE, our protection against respiratory viruses, but we typically, aren't wearing that for every minute of the shift. And during COVID, suddenly we're wearing N95s, not only during the patient encounter, but then after the patient encounter. And we're walking around with N95s all the time. And that was very different from kind of the standard way of doing things. So that's where you see photos of healthcare workers with the bruises under their nose. And as anyone who wears a mask know, it's a barrier between your mouth and everything else. So things like drinking water become like a little bit more complicated. And on a busy shift, it can be challenging to stay well hydrated. But that's something that I personally feel was like very challenging, just having to get used to make myself be able to take my mask off and be socially distanced and be able to get my drink of water in, because I think hydration is very important. Just those basic physiologic needs, in addition to all the other psychological stressors. Before vaccines came out and we were still dealing with a virus, it's still a new virus, but at that time was very, very new. And all of the uncertainty and fear that comes along with something that's new, just, going into every patient encounter and even interacting with our colleagues, kind of being afraid that one breach in our PPE, one mistake might lead to us getting sick and potentially having a very complicated course of the disease process, or even just letting down our colleagues and our health system, was a very real psychological burden that I think, I kind of take for granted now, being like fully vaccinated and boosted. PPE helps, but there was a very real fear of letting down our health system, our colleagues, our patients by getting sick. Another big issue was that, so under normal circumstances, there are small rural hospitals and they have a finite number of resources. And then there's larger urban hospitals that have more resources that can deal with more complicated things. Under normal circumstances, when a smaller rural hospital has a patient whose level of complexity demands more resources than they're able to provide, they will transfer that patient to a higher level of care at a better equipped facility. And that's just kind of how things work. When the larger facility is beyond capacity and is already struggling to deal with the patients that they have, it becomes a lot more complicated to transfer that patient there. And then when the smaller rural hospital is also struggling and is over capacity and stretched very thin, they're then forced to manage a more complicated patient than they're really equipped to manage until they're able to get that patient to the higher level of care. And this happens like during snowstorms and stuff like that, or things where the transportation becomes complicated. What made this different was that, it was an unprecedented pandemic, and both hospitals being full and everyone being stretched very thin and tired, but also wanting to do the best thing possible for the patient in front of them. That was also just a big issue, is managing complicated patients in smaller rural areas, or for the urban side of things, knowing that you should be able to accept that patient, but then having to deal with the reality of your circumstances and trying to do the best that you can. Those are some of the big things. The last thing that I'll mention is that there was, at the beginning of the pandemic, a lot of changes just in the way that we practice, based off the best information that we had at the time. And an idea that was floated around early in the pandemic, and there was a lot of ideas that were floated around earlier in the pandemic, and a lot of things kind of changed over time. But one example that I think a lot of people could relate to is that because there was a lot of uncertainty about the virus, and there was an emphasis on trying to limit potential exposure to the virus. So things like doing a physical exam on a patient, unless you knew it was going to change management, just doing everything possible to try to minimize the interaction, keep 6 feet apart, wear your PPE, all of that. And I think that does something to a patient when they show up, and everyone's keeping a distance from them, and maybe not doing as thorough a physical exam that they would under normal circumstances. I think that does something to a person when they go into the health system and experience that. And I think also for for healthcare workers, I think there's a level of rapport, I think, that gets developed when you're able to, see each other's face and be a little bit closer and do a physical exam. I think that makes a big difference. And I'm not saying that there was no physical exams being done, because that's not true at all. There were. I'm just emphasizing that kind of additional barrier and tension, I think, had some very real consequences, I think. I
Thank
can go
you.
on and on, but
Oh, this is great.
Thank you so much, Mark. It's incredible information that you're sharing. I just had a quick question. You mentioned stress among colleagues. Can you talk about emotions of patients coming into the ER and the effect that had on staff?
of the emotions that patients had and the effect on staff.
Yes, the emotions that are, the patients that are coming into the ER, obviously they have high emotion, they may be stressed, fearful. Did that have an effect on staff?
Yeah, I think, and again, these are all, I think I'm speaking in broad generalities, but people who work in the emergency department, I think, are accustomed to dealing with patients that are have very intense emotions because it's a traumatic experience. They're experiencing some kind of trauma and they are out of options, and that's the reason they're going to the emergency department. So I think healthcare workers are accustomed to that. I think something that was different with the pandemic was all of those other things that I mentioned, as far as constant changes and dealing with a lot of uncertainty, and the public also dealing with a lot of uncertainty. I think that created, or I think that could create, in some circumstances, additional tension. And also, as I mentioned with at the beginning of the pandemic, with that kind of calm before the storm period, with patients not coming in with the typical emergency department complaints, I think that the typical patterns of the emergency department were not happening in the way that they did before the pandemic. And then in addition to that, maybe, not getting as much hydration as you normally would, and the physiologic stress of things like that, in addition to the psychological stress of having to adapt to appropriately changing policies and protocols, and dealing with the reality of PPE shortages and all of these things that were out of control. I think those were the big things that were really different. Perhaps to get more to the what I think is the heart of your question is, I think seeing the way that the virus really, for lack of a better word, just decimated families and communities, and the impact that had on them, and seeing people having their loved ones really far away and not being able to spend one-on-one time with them in person, when that's what humans need to do, towards the end of life or in an emergency situation. And, having that not be the way that things play out just because of the reality of the pandemic, and hearing that a lot, I think, was a new challenge. I think too, for healthcare workers, something that was maybe more exaggerated than it was in the past was when people, hearing things from people that are training and experience, is hearing people say things that is different from our lived experience working in the emergency department, and goes counter to what our training tells us, and also what we're seeing on a day-to-day basis. And having it insinuated that lived reality is not valid or is inaccurate, or that the services that we're providing are somehow harmful, I think is, I think it's challenging to deal with that. And I think there's individuals in other professions who could relate to that in their own way. Yeah, does that answer your question?
It does, yes, thank you very much.
Could you go a little more in depth on how these kind of themes and these ideas go contrary to what is actually happening, what you're actually seeing? So we still have, maybe, sectors of the community that were impacted like others were, or don't really, didn't really see the, tribal communities were decimated. They were hit very hard early on. Resources. So we kind of see these in the smaller knit communities, but like in the larger community, right? You meet a lot of people that maybe didn't know a family member or didn't really have the experience that healthcare workers had, being there end of life and having to be the only resource or support that these, that our fellow New Mexicans had at that time, or, across the country, this was happening. Is there anything that I kind of just want to shine the light on that and kind of elucidate that this, we're still dealing with COVID. We still have, numbers are increasing. We still have, we're still losing, community members. It's still impacting, communities across the globe. But just sharing your insight, your perspective of like what that really looks like, I guess, like a little more in depth.
Sure. I'll start off fairly broad. I think a lot of people, like humans in general, tend to give a lot of credit or credence to their lived experience, and a person's lived experience should be validated. And when it's not validated, then that that does something to a person. A person needs to feel like they are being seen and that their experiences are valid. And as healthcare workers, we see a lot of people who experience very traumatic things, and we see the family members of those people dealing with it. And we need to be able to validate that. And then healthcare workers, being human too, also have a human need to have our experiences be validated. Another person might, live in a place where maybe their immediate social circle is not impacted by COVID, and that's their reality. And that's a valid experience to have because it's what happens for those people. I think what is hard for healthcare workers sometimes is when it feels like a person who hasn't confronted the challenges and the trauma faced by people who've experienced a different lived reality in COVID, and to feel like those people's experience is not being validated. I think that's a challenge, but yeah, does that answer your question?
No, that's great. We talked a little bit about fatigue, and we talked a little bit about it prior, and the fatigue that healthcare workers are experiencing, or just in the general public. But from your perspective, and from working with your colleagues and different, what is that like? And let's bring that out and talk a little bit about, because we're seeing this across the board in the community, and it's very real. Like the stress is very real.
Sure. Yeah. And I think for everyone, like this was a unprecedented pandemic. And I think everyone that has lived through it is fatigued and tired, and healthcare workers are no different. We have our own experience, and, a person who drives the bus is going to have their own experience too, and be very tired of everything in a different way. I think, there's been a lot of headlines and media attention to healthcare worker burnout and fatigue. And I think this is a positive thing in the sense that there's more attention being paid to mental health, not only for healthcare workers, but for the general public at large. And mental health has not gotten a lot of attention, or there's been a lot of stigma or taboo around it previously. And so this is one positive thing that we're seeing, is that there's a lot of necessary attention being paid to this. For healthcare workers, it is true that a lot of healthcare workers are leaving. Something that I find hope in is that a lot of healthcare workers are also staying. And so the healthcare workers who are staying are, and I'm not faulting anyone who leaves. Everyone has their own unique set of circumstances, and they need to do what makes sense for them. Healthcare workers who are staying are people that have worked through what I hope is the worst of the pandemic, and are still here and are dealing with the aftermath of the past 2+ years, and still show up to work and do the best they can with the circumstances that they have to provide the best care possible for the patient in front of them. And so that's something that I find hope in. But then also, again, that there is more attention being paid to, we need to do a better job of recognizing in ourselves that we, can't all be superheroes. We have physiologic needs. We need time to process things. And it's okay to not be perfect 100% of the time, and that we can't be perfect 100% of the time, but that we need to do things to take care of our mental health.
How can organizations like the Health Equity Council, what can we do within our reach, or, within the general public, to support healthcare workers like yourself? What things or advice, or how can we help support this very?
That's a great question. I don't know that I have an answer for that. I think so. The Health Equity Council has a role to play in public health, and I think when public health is working, it helps the healthcare system, because even though it's operating in the background and a lot of people don't see the way that it works, because when public health is working, you don't really see it. You don't even necessarily know it's there, but that helps the health system a lot. And something that I think did happen during the pandemic, and that I hope continues to happen moving forward, and it happened before the pandemic too, but just that partnership between public health and, what we call tertiary care, the hospital system, the health systems, because, I think when we're in sync, we can do a lot to preserve the health of our community, and that helps everyone.
So we have this, let me see. I'm trying to think, we've had guests talk about their fear of going to receive care. So we work with a lot of communities, undocumented communities that are really fearful to come out. So they were, experiencing a lot of really severe issues, and didn't seek care. And, is there a message that you have for them? Are they, so we're really trying to connect that how our systems are here, and that, people are welcome. You can get a vaccine. We're not going to ask questions. It's just come and get your vaccine. So really trying to break down a lot of those barriers. But during the pandemic, we saw a lot of families, and we talked to community members that didn't seek care, and some who suffered and didn't make it through the pandemic as a result. So from your perspective inside, what can we share with our community members? This is a safe space for them to, this might be more of a question that you may not be able to answered fully, but if there's anything that, our families being deported, is this something they should fear? We should fear. Is this something that public health needs to help address and bridge? Were there translators? Were there resources to help people in other languages? Things like that. Like, what could we do as a public health side to kind of boost that type of, make that connection and make it a safe space for communities, especially marginalized communities that are really in the margins and, the shadows, especially during this pandemic.
Sure, you ask a very important question, and I think this really is a team effort. Historically, there's been a lot of trauma that has happened to a lot of individuals and communities interfacing with health systems across the United States, unfortunately. And I think we do see the ramifications of that manifest in the form of mistrust or distrust of the health system for understandable reasons. I think more and more health systems are or have recognized that and are attempting to, one, acknowledge that harm has happened and that harm is real, and then also trying to create opportunities for improving so that it doesn't happen again. One of the things that is great about the emergency department is that no one gets turned away. So regardless of anything else, they are required to be seen. And I think we do the best that we can to accept all patients and all people, regardless of anything else, and to try to help them. And it really is a team effort. In the emergency department, we work closely with social workers and interpreters so that we can communicate with patients in their native language, and so that we can try to, if housing's an issue, help them find resources for a place where they can stay, at least temporarily, to the best that we can, try to connect people to services. The emergency department is a safety net for everyone. So people go to it as a last resort for a lot of things. And we want to be welcoming to everyone. We would never turn a patient away. And I think more and more health systems also are trying to expand on trying to help us better address the needs of very unique individuals and communities in a way that we haven't done previously.
Thank you. Yeah, thank you for that. Very important. I want to take a few seconds to remind everybody that we are giving our COVID tests in the lobby here, and that anyone, you are welcome to come by, pick up tests for your family, your place of work. If you're a school teacher and you would like to hand these out to your parents, that is, we want to make sure that everybody has these in their home, that they don't go untested because they don't have the resources. This is for everyone. This is free, no cost. We're very happy to have, provided over 13,000 tests to our community here in the city of Albuquerque and Bernalillo County, and we want to continue to do so. We want to keep providing and being that resource. Also, we have PPE, we have hand sanitizer, and we have cleaning solutions and packet boxes that you can take to your place of work. You can take them to your restaurant, your business. They're free of charge, but we just want to get them in the hands of everyone. Especially, we realize that they're expensive, there's locations that don't provide them, and we just want to make sure that everyone has access to that. So we are at 220 Suite A, Adams Southeast Albuquerque. And so, yeah, you can drive up, and our executive director, Enrique Cardial, will greet you at our door And you're welcome to, and if you just don't have time this evening, you're welcome to send us an email and come in anytime during the week. If you're at the University of New Mexico, you need them for students, these are free for the public. We just want to make sure that people have access to tests. And so that is, and we also have in Spanish and English how to use them. So we have resources and we just want to provide and get them out and let everyone know that we're a hub. And if we don't have what you need, we will figure a way to get that to you through our other community network partners. In our talks in the past, we've had harm reduction specialists, we've had tribal leaders, we've had a lot of different resources and individuals come on and really talk about, and we have this great network. So we have lots of information and resources that we can get out and share. Also, if anybody needs help or assistance getting a vaccine or signing up or knowing where the vaccine events are, they're welcome to contact us also. So we want to be that hub and that central location where everyone can come to and we can connect you with the right resources. And if we don't have the answer, we'll find it. I wanted to introduce also, we have another guest here, Joseph Strogel is the epidemiologist. If you wanted to say hello real quick.
Hello, everyone.
Excited to have this team. Especially, and just thank you all for taking it, Mark, for taking time this evening, out of your day to come talk with us. This is, these are some of the mental health pieces and just so many pieces that we haven't discussed, and really, really great points and thinking through and providing just information to like our audience and our public. So we're really grateful. We have about 15 minutes. I wanted to be, kind of open it up for conversation or dialogue if anybody has any questions. And I also want to give a shout out to our cameraman right here. So if you wanted to come over and say, so we have this team, we have this really good team here. This is Matt. So at the Health Equity Council, and we all just take on different roles. I'm a medical sociologist and I'm putting together puzzles and do a lot of research, and the puzzles we do, we kind of build programming and presentations, and not just presentations, but really try to find the root causes of maybe, disparities in health, disparities in COVID around certain communities and things like that. So taking it to a different level, work around policy. And we have so much, promotion specialists, community specialists. It's amazing. We have Anna, who just keeps everything, all of us just organized, and she's a public health practitioner just out there as well, connecting in the community. So this is just a very small glimpse of our team. And so we just thank everyone, joining us. Mark, I really wanted to give you the opportunity, is there something that you wanted to share with the public or ask the public, to do, or, just any type of like insight, if you could share, moving forward with all the knowledge that you gained through all of this time, if there's something, that you want to encourage the community, let people think about.
Sure. I guess I would have like a few kind of summary points. So one would just be that, maybe all of this feels kind of normal now. I don't know. But that this really was an unprecedented pandemic, and that healthcare providers in the health system really were doing the best that we could with the information and resources we had. And that, most people go into healthcare because they want to help people, and that it's very painful when you can't provide the quality level of services that you'd like for each person in front of you. But then also acknowledging that, that doesn't make the experience for any individual any less painful. So I guess that would be my first point. The second issue I would just say again is that timely and accurate information is critical, and having reliable sources of information, particularly in times of an emergency, is very important. And for that information to be relayed in a compassionate manner and to acknowledge when uncertainty exists and when answers aren't known. And then also to acknowledge when mistakes were made or things could have gone better, I think is also really important. A third point would be that regardless of whether it's COVID-19 or some other kind of public health or social crisis, is that we need to be able to come together as a community, and finger pointing, blaming, profiteering, isolationism, and disjointed efforts are not productive during normal times. And when there's an emergency going on, are counterproductive, and they can have very deadly consequences for a lot of people. You know, basic structure for having a unified strategy and coordinated efforts is something that's used by the military, by police forces, by multinational corporations, by fire departments, and by any agency or field that is addressing large and complex issues. And public health and healthcare are no different. And we have the structures, I think, and the capacity to do that. And we did see it to some extent in the pandemic, but just to reiterate that it really needs to be a coordinated, unified effort and strategy that adapts to information that's provided in real time. And then my final point would be that public health and healthcare systems are taking steps and trying to acknowledge past harms that have been done to communities and individuals, and that progress has been made, but a lot of work remains to be done as far as that goes. I think we've seen this around the globe, where when communities don't trust, the government or a health system, that has detrimental consequences when a public health emergency plays out. It has detrimental consequences under normal times, but even more so, during a public health crisis. And that we really need to represent the communities that we're serving and have, members of all communities being voices within our health system, because they're the ones that are gonna ask questions that won't be asked by people who are outside of their community. And they'll have an insight and perspective and a level of expertise that can't be taught in schools the way that lived experience can teach it. And so really, in order for us to be really effective and to make our healthcare system, which is flawed, the best healthcare system that it can be, we need members of those communities to help us make things better.
Thank you. Thank you so much. This is really good. I really want to thank you for, and I think all of us at HEC Phil, just for all the work that you and all of the healthcare workers and frontline workers and everybody out there, EMTs, that just this concerted effort to serve our community. So I just want to give you, just say how proud we are of you guys coming together and really taking care of our families. And that's kind of how I think about New Mexico, and I think of us as a family. And I think of the HEC and the public health and all of the, that's why it's Querencia, because we love our family, we love our community, and just really grateful for all the healthcare workers, just every morning getting up, not knowing what the day was going to be like, but taking that risk to save our families' lives and for allowing all of this. So I just want to thank you, Mark, and just let you know that we recognize you and all the work that you guys have done. So I don't know if are there any of our other co-hosts here want to share anything.
Just real quickly, Mark, I just want to echo what Carmela has said and express our gratitude and our thanks for your information that you shared today and, all the work that you and your colleagues have done throughout this whole pandemic. It's amazing, and just want to say a heartfelt thank you.
It's very kind of you to say, and I would say thank you to you as well. I have tremendous amount of respect for people who work in public health because you provide a critical service that I think doesn't get as much funding or resources or appreciation, because as I was mentioning earlier, and you would know this better than I would, when it's working well, we don't see it and we kind of take it for granted, but it is so critical for the health of our communities and the well-being of everyone, really.
Thank you, Mark. I really appreciate you even just acknowledging, because our communities do have a lot of mistrust around the medical system, and just acknowledging that and thinking about bringing in order to build a better system. That's what New Mexico, that's what we really need. And I thank you for honoring those voices of individuals. And hopefully we can connect individuals from the community, with others in your department and your field. We're helping to build, equity and inclusion, really thinking about how you guys provide resources and to our marginalized communities, our communities that don't, won't get services or have very hard, times in the past or historically. So, that's the first step, really acknowledging those things. And I think that's how we build a better New Mexico and a better system for our families. So I want to tell you, thank you so much. And of course, a big shout out to our HCC team, because we have, the other end of our public health, providing the vaccine. So we have the coordinators and the outreach that organized this entire system, as a huge concerted effort to get the testing, those lines that you saw at the state fair and all of those sites, and getting the vaccines, that they're right here, right? They were in the front lines on that end. So just thinking all these different, it took a community, it took so many different pieces. And so it's great that we're all able to come together and think of, thinking through how we move forward and what that's going to look like. And I think that is pretty much all that I have. I want to say food aloha. Thank you very much.